Hi, my name is Nathan Tanner. I'm the founder of the Airway Center. I'm going to explain some of the history and cultural causes of some of the problems and issues that we face today. There's going to be a couple of short 4-minute videos that help explain some of this. And then I'm going to show some cases and how we treat and help children with this. There's a silent crisis in America. On the left is many of the signs and symptoms that children experience: ADD, bedwetting, difficulty in school, mouth breathing, snoring, restless sleep, delayed growth, nightmares or night terrors, low IQ, allergies, crowded and crooked teeth, dark circles under the eyes, swollen tonsils and adenoids, and daytime drowsiness. On the right is a list of signs and symptoms that many adults experience during their lives: depression, anxiety, fibromyalgia, obesity, hypertension, aggressive behavior, bruxism, grinding or clenching teeth, cardiovascular disease, Alzheimer's, opioid addiction, diabetes, dementia, cancer, and premature death. Research has shown that 9 out of 10 Americans suffer from one or more of those conditions. Looking at children today, do these children look healthy? We see a double chin on this young man. We see some dark circles under this lady's eyes, some stippling on the chin, thin lips. We see a crease on his chin, a little bit of a head tip. His shoulders are offset a little bit. This young lady has kind of a narrow face, small jaws. Her head's not symmetrical. We see an underdeveloped jaw here, kind of buck teeth, and dark circles under the eyes. Do these children look healthy? And more, this kind of look is becoming normal in day-to-day society. There's this short video showing a young man who was filmed sleeping and what happens while he's trying to sleep.
That was holding it. He's still holding it. He's trying to take in air. There he goes. Okay, now watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and now he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. He's trying to... There he goes. So this has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now, watch what happens when I take his jaw and I just bring it forward. If I can. Let's see if I can. And I open his airway. Just bringing his airway forward. Now listen to the quiet breathing. There we go. Now he's breathing through his nose.
So when his jaw is positioned properly and his tongue's not collapsing and blocking his airway, his breathing is much better. Which one of those is healthier breathing while he's sleeping? With the tongue blocking the airway repeatedly, or when he has his jaw positioned and supported and we have good healthy nasal breathing? I think we can all see a difference. So these are a lot of the signs and symptoms we see in children who have breathing like that during the night and repeatedly throughout a lifetime. An underlying cause of those is a compromised airway. Some possible root causes are underdeveloped upper and lower jaws, our diet, our tongue muscle, and orofacial posturing, and the way we breathe. And excess sugar intake also has a big effect on this. Has it always been this way? 200 or more years ago, crowded teeth did not exist. Nobody had impacted wisdom teeth. Everybody had all their teeth perfectly straight in, their wisdom teeth in, and 10 millimeters of space behind the last wisdom tooth. There was even room for a fourth wisdom tooth. How has this happened now that more often than not, children have crowded teeth and impacted wisdom teeth? Dr. Robert Corcini is a dental anthropologist that has studied this his whole career, and he's done a lot of research and published a lot of books and articles showing the causes of these underdeveloped jaws and poor airways. Consistent findings show that rural populations have no processed food, no processed sugar, hard food diets, and little to no incidence of crooked or crowded teeth or degenerative diseases, and well-developed jaws and optimal airways. So he shows that dietary consistency and the healthy diets are very helpful for us to have fully developed jaws, and the soft diets, or what we call the Western diet, leads to underdeveloped jaws. Malocclusion or crowded teeth is not a genetic mutation. It takes 27,000 years for a genetic mutation to express in a population. What he found that by Western culture and the Western diet, within the first generation, 50% of the kids have underdeveloped jaws. The second generation, 70% of them. The third generation, 85% have underdeveloped jaws, crowded teeth, and begin to have this cascade of signs and symptoms. Today, our generation is about in the 8th generation of this degenerative decline of underdeveloped jaw structure and poor airway health. Why do so many children suffer from this? Excess sugar, poor nutrition, soft food diets are some of the factors. In 1900, the average person ate 6 pounds of sugar a year. By 1980, that average was up to over 150 pounds of sugar a year. So currently today, every 2 weeks, we get what used to be in 1900, 1 year's worth of sugar. This is a 4-minute video showing, because of the Western diet and what's happening to our underdeveloped jaws, this is what happens to our airway.
Just a few hundred years ago, the human face was different. It was forward grown. Her wide profile and large dental arches ensured straight teeth and room for her tongue. Most importantly, she had plenty of space behind her upper jaw so she could breathe through her nose with ease. The modern face has changed. From childhood, her dental arches are less developed, crowding her teeth and giving her less space for her tongue, which impacts her airway. Many believe this stems from a number of causes, such as allergies that affect breathing. Another is the poor nutrition and softness of modern diets, causing toddlers to have underdeveloped chewing muscles and smaller dental arches. Because her upper jaw is too far back, she will struggle to breathe normally through her nose. To get more oxygen, she will compensate by opening her mouth to breathe, bringing her lower jaw down and back, creating a downswing of the face. This is how her undergrown upper jaw creates the appearance of buck teeth. She's actually compensating in order to breathe. If not corrected, the problem carries into adulthood. Extractions were documented in the 1600s as a way to treat crowding. Although they are a quick fix, they don't treat the problem of underdeveloped arches and have been implicated in harming the facial profile, making them the subject of much debate even today. Adulthood. In order to breathe, she will slouch her head forward to prop open her airway, creating a lifetime of neck and back pain. This is the infamous forward head posture. Having a healthy airway is crucial to the survival of life, and especially so during sleep. When muscles around the throat relax during sleep, a healthy airway stays open because the tongue is sitting forward and has enough space to be suctioned up against the fully grown palate. With underdeveloped jaws and dental arches, the palate is too small for the fully grown tongue, which is sitting back to begin with. When she sleeps, her tongue does not suction, rather it falls back and cuts off her airway. This is obstructive sleep apnea. Like crooked teeth, it's a modern condition, however, it can reduce life expectancy. Not surprisingly, obstructive sleep apnea is marked by the same traits that describe the headgear effect. Both jaws are grown down and back, creating a clockwise rotation in the lower third of the face. The myth of the overgrown upper jaw that needs to be held back has long since been replaced with science. Science has shown that young children can be buck-toothed naturally, and that the lower jaw catches up over time with a fully developed upper jaw. Essential to this is nutrition, the use of chewing muscles early on in life, and good breathing habits. This means breathing through the nose with the mouth closed and the tongue resting up against the palate. Also, the practice of maxillary expansion has been shown for over a century to correct crooked teeth and improve nasal breathing space. And since 1918, orofacial exercises have been shown to correct mouth breathing habits.
Normal craniofacial growth is mostly done by age 2 for most of our head. The lower part, and especially our midface and lower jaw, develops significantly from age 2 up to age 17. And there's a forward and downward component to that growth. Today, more often than not, our jaws are growing downward instead of forward. The more our jaws grow forward, the more ideal development for our jaws, our teeth, and our airway. The more the jaws grow downward, the more restricted our airway is going to be, the more crowding we're going to have. Age 2, our jaws are about 55% developed. By age 4, about 75%. By age 12, we're about 90 to 95% developed. This is showing on the left, the more there's an underdeveloped upper jaw, it's smaller. There's less room in the mouth for the tongue. When the jaw is fully developed, there's more room up on the palate for the tongue to be. Does straightening teeth or traditional orthodontics solve the airway problem? Dr. Christian G. Minot, he's a cardiologist that was at Stanford in the 1970s, and he was having a lot of complications with his patients after surgery. He had his nurses stay awake and watch the patients to see what was happening during the night because they didn't have all the monitoring equipment they have today. They reported back how they're having these breathing disruptions and airway disruptions during sleeping, and he was the one that discovered obstructive sleep apnea and found when we treat the sleep apnea, people need less surgery. He's the one that discovered and defined obstructive sleep apnea, upper airway resistance syndrome. He created the apnea-hypopnea index, which is how many times you stop breathing every hour when you have sleep apnea. And he started developing the solutions to this. In the 1970s, he was doing a tracheotomy, a hole in the throat. You open that, breathe through your throat at night while you're sleeping, bypassing the tongue. We saw in the video the little boy, his tongue blocking his airway where he had those disruptions in breathing. This bypasses that narrowing. You close it, breathe regular during the day. In the 1980s, he helped develop the CPAP machine, continuous positive airway pressure. The air pressure is a fan that blows the tongue forward to keep it from collapsing and closing the airway. Then middle-aged people began needing the CPAP machine, and now children need the CPAP machine. Cancer and sleep apnea used to be diseases of the elderly. Today there's pediatric cancer centers and pediatric sleep centers, support groups for children getting put on the CPAP machine. Dr. G. Minot said, if we can make room for the tongue and the mouth, we may be able to eliminate the development of obstructive sleep apnea. If you consider a straw or a garden hose as an airway, which one would you want to have to breathe through? And another element of this is the collapsibility. If you suck through that straw hard enough, the inside wall in the middle can collapse in and block the airflow. And that's how the tongue gets pulled back and restricts the airflow. Something with a larger diameter is less prone to that collapsibility. Here's a functional airway. We see the nasal cavity with the air going through the nose, our nasopharynx, oropharynx, laryngopharynx in the back. So this area back here is the primary area. The more forward the jaws are, the more forward the tongue is. The more forward the tongue, the more room for airspace right here. The American Dental Association has created a task force put together to have children's airways screened and evaluated and proper recommendations given to help children the best they can. These are two different people. On the left is a person who see the neck and the airway, the tongue and the front teeth. And then on the right, a neck, airway space, the tongue and the front teeth. So if these two people lay down to go to sleep at night, whose tongue is more likely to restrict the airflow? Who's more likely to be told they may have exercise-induced asthma? They may need an inhaler to help get more oxygen. So the way we do orthodontics, having a difference of 1 or 2 millimeters of space in the front of the jaw can potentially have a big effect on the back of the jaw or the airway as well. Here we have normal breathing, normal airflow with the jaws and the tongue forward, and then blocked airway with constricted breathing and the tongue falling back to block the airway. Dr. John Remmers is a world expert in the field of snoring and obstructive sleep apnea, the first research to determine and demonstrate that sleep apnea is caused by that anatomical narrowing of the pharynx. Structural narrowing plays a critical role in most, if not all, cases of obstructive sleep apnea. Obstructive sleep apnea would not exist if both jaws were placed properly forward in the face. And here again is the straw and the garden hose, showing how the smaller that front to back narrowing is, the more collapsible that is. This is a 4-minute video of one child and his mom describing his story of what she went through to find the source or the cause of his trouble that he had in life. Dr. Karen Bonnick also has done the biggest research study with 11,000 children, finding that when there's sleep disordered breathing in children, their IQ goes down as they're growing up, which normally in healthy children, our IQs go up as we're learning and growing. This is a short video by Dr. Ben Merelia about ADD.
Now take a child, alter their quality of breathing and sleeping. And the real big issue now is how will they be during the day? So now you take a child who's 5, 6, 7, 8, it doesn't matter. Their issue has begun years ago. So it's not like you had 1 or 2 bad nights of sleep. You've had a poor quality of sleeping and breathing for years. And the parents have been struggling with so many different issues, and not the least of which is the ADD, ADHD discussion. Because the child who doesn't get a proper night's sleep with a good quality of breathing throughout the entire night is going to wake up and be unrested. And when you get a child who's had a poor quality night's sleep, poor breathing all night long, and you make that happen for years, you know what you've got? A 6, 7, or 8-year-old that's going to go to school and have trouble learning, have trouble sitting still, have trouble behaving, have trouble cooperating, basically have trouble fitting in to what is supposed to be a quiet and peaceful and learning environment. And it's not long after that where the phone call comes to the parent. And when the phone call comes to the parent from the school, what happens is, we have little Jimmy here and he's a little bit disruptive and we really want you to have him evaluated for ADD and ADHD. They're going to be diagnosed with ADD and ADHD. And our solutions are pharmaceutical. If we are given a pharmaceutical, it's usually in the form of some sort of a stimulant. And what that does to the child is it kind of pushes them over the edge and it brings them back to calm. So you basically take an excited or hyperactive child, you stimulate them more, and you bring them back to a so-called calm. But it doesn't make a better learning child. You're not going to have a child who's able to learn as well. So now you might have the child sitting still in class because they might be a little more numb or relaxed or calm, but it doesn't necessarily make them a better learner. If we have the so-called ADD, ADHD diagnosis, we're talking about hyperactivity. We're talking about all of the things about behavior and development that land in this category. And the interesting thing about research is, and there is current, ongoing, and past research that shows, children who are sleep deprived produce the same exact symptoms as kids who are diagnosed with ADD and ADHD. In fact, there's a nice study that showed children who were diagnosed with ADD and ADHD were mixed with children who were sleep deprived. And in that group of kids, when they tried to analyze them and look at their symptoms and diagnose them, they couldn't tell them apart. And if you have a group of kids and you can't tell apart who's an ADD child and who's a sleep-deprived child, it's no surprise that maybe the ADD and ADHD has a cause. And maybe that cause has to do with the quality of the breathing and the sleeping overnight. And there's a lot of research out there. And one of the pioneers here is Dr. Stephen Sheldon out of Lurie Children's Hospital in Chicago. And he does a wonderful job of researching, and over the decades, he's come to a conclusion, and I've seen him speak, and it's not soon after he jumps on stage and he makes a statement that ADHD and ADD do not exist. They are an outcome of a sleep disorder breathing. They're an outcome of a poor quality of sleep. It's all about the quality of sleep. Another researcher who's produced beautiful research on the same topic is Dr. Karen Bonnick out of Einstein at Yeshiva University. Dr. Karen Bonnick has the largest study to date. 11,000 children were watched over 7 years. And they were divided into 2 groups, sleep disorder breathing children and children who do not have sleep disorder breathing issues. The children in the sleep disorder breathing group, over their 7 years, her study showed that they were 50% more likely to be diagnosed with an ADD or ADHD diagnosis and treated with medication. 50% is a coin toss for our child to be diagnosed and treated with a medication. Also in her group, they were doing testing. They were doing IQ or intelligence testing along those 7 years. And the children with the sleep disorder breathing, their intelligence testing, their IQ scores were dropping over those 7 years. And that's really not the way it works when you're growing and forming. The formative growing years for a child, when they're sleeping and breathing well, your IQ raises to a certain point and then you kind of plateau. We don't see IQs diminishing amongst children.
So what can we do? It may not be what you think. We try to promote healthy nasal breathing, discouraging or eliminating mouth breathing. Nasal breathing is so important to warm and filter the air. We train the tongue to swallow and position properly. We eliminate tongue thrust or reverse swallows. We get forward jaw development, natural principles of bone growth and development to optimally develop the jaws upward and forward, increasing your airway, improving your breathing, making room for all of your teeth, giving you a broad, beautiful smile. What do we do to evaluate the progress? The indicator line is a measurement created by Dr. John Mew in the 1950s, measuring from the tip of the nose to the edge of the front teeth. The more downward growth, the higher that number becomes. The more forward the jaws grow, that number tends to stay a little bit smaller. There's a little chart here. Based on age, there's optimal or ideal number of measurements of where that should be. There's the Bolton standard based on the Bolton breast study in the 1950s. This is a silhouette profile over the head and face. The farther back the lower jaw is from that line, the more restricted the airway may be. We also look at the nose-lip angle. The higher the nose-lip angle, that's a sign the jaws may be farther back and more underdeveloped. And then we use the echopharyngometer, which is a machine that measures the airway using sound waves to quantify how much airflow is happening. Here's a patient at age 12 who came in, was doing okay, but based on the indicator line measurement, we could tell that the direction of growth was going more downward, down and back, than it was forward. And we saw this happen. A couple years later, age 14, you may notice the lower jaw getting set back a little bit farther back, and the airway may not be as healthy also. Here's someone at age 2, all the baby teeth in, a little bit of crowding here, but what I want you to notice is the upper jaw has already grown down too much by age 2. The upper jaw has grown down instead of forward, locking or trapping the lower jaw behind it. So now the lower jaw's growth is restricted. It cannot grow forward because the upper jaw has blocked it and trapped it back. This girl wakes up crying twice a night. Now, if we're going to try to develop her jaws or do some kind of orthodontics, most people are going to say, well, let's wait till she's older and gets her permanent teeth in. But what we do is we make an appliance that develops the upper jaw up and forward, unrestricting the lower jaw. We did not do anything to the lower jaw, but all by itself, the lower jaw begins to grow out and forward, and this young lady started sleeping through the night every night. At age 2, she was not potty trained. Most children, after they potty train during the day, they still wear diapers during the night. At age 2, not potty trained, she started waking up with a dry diaper every single morning, but wearing a diaper during the day because she'd still have accidents during the day. But that's a sign of the quality of sleep. And when we're getting good REM and deep sleep cycles, we're not bedwetting. We're not getting up and going to the bathroom. Here's a young man, age 5, all baby teeth still, underdeveloped jaw. You see a forward or head tilt chin lift posture. That's an airway breathing posture. If you've taken a CPR class and lay this boy down, he's giving himself a head tilt chin lift to open his airway. We develop his jaws out and forward, correcting the direction of jaw growth. And you can see he has a stronger, more defined lower jaw. There was plenty of room for all of his permanent teeth to come in. No crowding. Sleeping better. He went from wetting the bed twice a week to no bedwetting through better, deeper sleep. This young lady, age 6, no space between the baby teeth. You can see some wear here from the grinding. Lower jaw, again, trapped back. So these kids get older and grow bigger, but their jaws are not growing as optimally as they should. There's no space for the permanent teeth to come in. And the normal traditional thing is wait till the permanent teeth come in crowded because there's not room for them, and then straighten them. But as we already asked, how much does straightening help with the airway? What we do is we develop the jaws forward, making room for the permanent teeth. So we grow the bone. When we develop the bone, now there's room for the permanent teeth to come in. These are all the same baby teeth that were over here. Now there's plenty of room for the permanent teeth to come in. She has better jaw structure. So here's her lower jaw set back a little more. a little more of a forward head posture. Her jaw in a better position, unlocked, developed, better airway, and all of her teeth come in without crowding. Age 7, crowded teeth. He had no space between his baby teeth. Permanent teeth came in crowded, still bedwetting. We developed his jaws forward, plenty of room in his mouth, opening his airway. You see a stronger lower jaw there, significantly improving his sleep quality. Here's his front shot. So at age 7, his upper jaw had grown down too much, trapping his lower jaw back. Gummy smile, flatter cheeks there. We get the upward and forward growth, reversing the gummy smile, getting the upper jaw upward, more prominent cheeks, better smile. Here's a young lady. All of her baby teeth were perfectly straight. The permanent teeth came in very crowded. She needs one premolar right here. Traditional treatment techniques or standard approaches would maybe take out some baby teeth and then down the road maybe get some permanent teeth even taken out. We take this lady, we develop her jaws up and forward, developing and growing the bone. And now that little space there becomes this space right here. We have more than enough room for one tooth to come in right there. And as all these back teeth migrate forward, there's more room for the wisdom teeth later when she's older, and she's not going to be faced with having any permanent teeth extracted. Here's her front shot, smiling, a little bit of a gummy smile, better smile, straightening up those teeth. Here's her nose-lip angle, kind of flatter cheeks, very high nose-lip angle, flat upper lip. And here we get better cheeks, smaller nose-lip angle, fuller lips, better lower jaw. Now over here, when she's in her 20s or 30s, she may start thinking about some kind of dermal filler or filler in that upper lip. Here, she's going to be more okay. She doesn't have as much of a flat lip there. Here she is smiling. So you see on that smile, that really flat lip coming up. She's going to want to have a better lip when she's a little bit older. Right here, that lip looks better. But what we can see is the upper jaw coming up and forward, closer to the nose, reducing that indicator line. Here's another young lady. She had a little crossbite going on. She was having headaches about twice a week. These are all of her baby teeth, permanent teeth just starting to come in, but there was not room for her permanent teeth to come in. She was headed toward significant crowding and underdeveloped jaws. With this bite pattern, she was locked in. This was going to fall down and back. Her direction of growth was not ideal. But instead of letting that happen, we kept her jaws growing upward and forward in an ideal growth pattern. You can see the lower jaw coming out ahead of the bridge of the nose. So on that Bolton profile, this is a better profile here. And we have a small nose-lip angle, a better airway, no crowding, room for all of her permanent teeth to come in. Here's a case who was recommended to have 4 premolars removed. So normally they take out these premolars here to give room for the canines to come into those premolar spaces. The canines are in the right spot. We grow the bone, not removing any permanent teeth, and there's a much bigger mouth and better airway. Here's another case. Normal traditional treatment would take out 4 permanent premolars, top and bottom, to bring those canines into position, just like happened to his father. And what we did is we grew the bone, and he had fully developed jaws, no removing permanent teeth. And when we started this case, the parents weren't sure if this could really happen. They didn't know if this was possible. They're so grateful for the outcome of this child and how good his result was. This is a young lady who, this is at the end of 2 years of traditional orthodontics. You see a little bit of a forward head posture here, which is an airway compensation. So after 2 years of traditional orthodontics, this young lady started having some symptoms, struggling breathing, snoring, restless sleep, distracted, neck pain from this forward head posture, buzzing or ringing in her ears. And this is at the end of what we call traditional orthodontics. She had the class 2 elastics, the rubber bands between the upper and lower jaws that tends to be restrictive or bring the jaw growth down and back, which is not ideal for the airway. So here she is after 9 months of treatment, getting the jaws going forward. Her symptoms go away, the ringing in her ears go away. You see she gets a better jaw development, better airway here. This is on the Bolton. So we see the lower jaw really set back when we started. A year later, she's much better here. This is her airway. So the black is the smallest, then the red and the yellow and the green. So she had a very, very restricted airway. After we developed her forward, her airway was significantly improved. This is a cross section. 5 millimeters front to back is her airway space, and now it's over 10, and it also increased in width. So getting those jaws forward every millimeter can make a significant difference on breathing. Here's her profile. This young lady was treated by somebody who does airway-focused orthodontics down in California for 3 years, and she came up to Oregon, and I said, I still think she has an airway compromise. Her wisdom teeth were impacted. We put her on a monitor. We saw these oxygen drops during the night and the heart rate spikes, and that's a sign of disrupted sleep. We helped develop her jaws. She went from mouth breathing to nose breathing. She had a stronger lower jaw, better profile, smaller nose-lip angle, breathing, sleeping, feeling better. 9-year-old boy, 13 times an hour, every hour during the night. He's in respiratory distress, having nightmares and night terrors. Within 2 weeks of treatment, his night terrors and nightmares went away because we unlocked the lower jaw and allowed it to develop forward and open the airway. This is a 7-year-old son. 4 times an hour, he's in respiratory distress. And within 2 weeks of starting his treatment, the mom came in saying how coaches, teachers, friends, parents are asking if he was on medication because he was sleeping so much better now. So opening his airway made a really, really big difference in how he felt and performed every single day. An airway center doctor can help determine if you are a good candidate for the Breathe Easy treatment. The first step is have your breathing evaluated with an echopharyngometer, which measures the airway with sound waves. Get an overnight sleep evaluation. Have your indicator line and nose-lip angle measured. Have your profile evaluated with the Bolton standard. To find a dentist to work with, visit airwaycenter.com.